So good afternoon, everybody. It's a great pleasure for me to introduce this webinar that is part of the ERN, the European Reference Network. The art, this is the GUARD-Heart session. We will I will chair this session with my colleague and friend Philip Munz. We have a very great panel of experts for this new subject. The webinar will try to explore this new subject, this new issue that is related to the frailty in congenital heart disease patient and their families during all the life stage. We have 4 speakers, Dr. Caruso, Dr. Abid, Dr. Silman, and Dr. Magon. And maybe we may start with the first speaker, Dr. Rosario Caruso from Milano, that was at the head of our research nurse department until the last few weeks, but he moved to another hospital and we really miss him. Please, Rosario.
Yeah, thank you, Massimo. It's a pleasure to be here. Thank you for the floor, but we will do a lot of work together. So it's just, let's say, a location move, but what we started to do is something rooted in the field. And I would like to say that now the topic of frailty management, which is the topic of this webinar, is a specific field of clinical practice that actually involves all the professionals involved in the care of individuals and families with a congenital heart disease. So my presentation would like to share with you some insights regarding the evolving concept of frailty, how we can assess frailty status, and how we can manage this condition. So the first message I would like to share with you is that frailty is a multidimensional construct. This means that when we speak about frailty, we speak about several aspects of the life of individuals and families. So if we move towards the definition, the first point we have to consider is that frailty can be understood as a multidimensional construct, but also as a paradigm, as a phenotype, as a way to move forward the focus on disease stability and embrace the complexity of the life of individuals and family with a congenital heart disease. So the early definition of frailty has the origin in the 50s in the gerontology field. In the evolving literature and definitions, we see different additional aspects that now define what frailty is. Frailty encompasses the physical cognitive domain, the psychological domain, and the social domain. And it's the interplay of these domains that define a complex multidimensional status of our patients. We know that frailty is linked with the physiological reserve of individuals if our focus is the individual, or the entire family if the focus is the family as a let's say, cluster of individuals. We also know that frailty is associated with sensitivity to stressors across the entire lifespan. What does it mean? That frailty is not a consequence of advanced age, it's a status that we can also assess from the prenatal phases of life, so to the early stage of life after the let's say, neonatal care, and in the pediatric care up to the gerontological area. So in the individuals with a congenital heart disease, frailty can emerge earlier simply because it's triggered by several procedures, treatment burden, and cumulative social and family stressors that can trigger a state, the phenotype, what is the status of frailty, or in some cases, pre-frail conditions. So we have to understand that frailty is something that can be understood in each meaningful stage of the life of our patients. And moving beyond the stability is something that requires a paradigm shift. It means that we are asked from a research standpoint or a clinical standpoint to move from tracking disability alone to comprehensively assess the other part of the continuum of the frailty condition, which is the resilience capacity of individuals and families. So what does it mean? That this paradigms includes the need to enhance the system capacity to design care path able to consider functional abilities and role performance of individuals and families, cognitive capacity, social participation and engagement, and of course, family system functioning. So it means that embracing the paradigm of frailty enables researchers and clinicians to anticipate every item of the very definition of frailty, which are different vulnerabilities aspects that can be retained by the domains of physical, psychological, or social area. We know from the approach to study that if we look, for instance, the adults with congenital disease, more than 40% of participants had a pre-frail status. What it means that the proportion of people living with a congenital heart disease in the middle age and older adults are in a pre-frail condition. And if we consider this fact also together with the elements I said before, so the fact that the individuals live in a family context, sometimes we have individual patients with a pre-frail condition with parents which can be frail. So if we look at the cluster of family, the embracing frailty with this paradigm enable us also to work on the entire family. If we look in the literature, we crossed four main phases. However, now we are in a phase in a phase that require the translation of the research to practice. So frailty cannot be something considered as an abstract label because it requires to be something that allows researchers and clinicians to design concrete interventions to anticipate issues, to anticipate declines, not only in terms of clinical stability, but in terms of keeping patients and families within a safe areas. So to do this, from a research standpoint, we have to inform clinicians with actionable evidence. We have two major families of analytics that can help to do this. One is the analytics that allows researchers to identify similar subgroups just to facilitate the standardization of the approach, because standardization is the pre-phase of the personalization. Standardization and personalization are not opposite, let's say, approaches, but standardization is the pre-phase to achieve a real personalization, a feasible personalization, a sustainable personalization. And this can be doable with analytics rooted in the cluster analysis. Another important families of analytics is the network analytics, because this allows us to understand within each domain which aspect, which vulnerability can trigger all the others, just to inform clinicians in the care path when we have different areas and we have to say, okay, but I have this, this, and this, where to start? To give these answers, network analytics can be very helpful to allow what is called clinical translation. So, of course, as I said before, frailty is a family affair, and the model of care that can be used to address the challenges of embracing these complexities is the integrative care. Here, I would like to suggest everybody to read the paper published in the European Journal of Cardiovascular Nursing. It's a position paper of the ACNAP group that define what is integrative care, and frailty can be considered as a paradigm, not only a phenotype or a condition, but a paradigm that has as a natural match the integrative care to tackle the challenges around this definition. So this approach requires a coordinated organization of care across different services, family-driven approach, transdisciplinary teams, because we have the nursing professionals that can design and coordinate some activities, and also require some activate specific specialized consultation with different specialists. And the point is that the definition of integrative care, it's quite well defined, and the underpinning message is that all the interventions required to assess and address frailty are complex interventions, which means that also from a research standpoint, the ways to see how to organize feasible and evidence-informed interventions have to consider this definition, the definition of complex interventions. Going to my conclusion, I would like to say that at the very end, considering frailty, so also frailty as a continuum from a good resilience capacity to pre-frail and frail, if we consider frailty in this way, frailty is a compass for the designing and delivering this personalized care, because frailty can allow clinicians and researchers to stratificate the population and target different interventions, involve the family assessment in the plans, and consider the integrative models as the models that can be used for addressing this this paradigm. Is not really a new paradigm, because frailty, as I said, was defined in the 50s, but now with all these elements from the analytics to the theoretical definitions, we can say we have a new era where we are asked to do actionable research designs rooted in the data that we are able to gather with the technologies that we have. Thank you.
Thank you very much, Professor Caruso, for this first presentation on frailty management, the concept, and so on. I would propose that the participants in this webinar keep the questions until the end. And therefore, I would like to go to the next speaker, that is Hajar Habibi. She is the lead clinical nurse specialist at Royal Brompton Hospital in London. So she is best placed to both combine research and clinic. So, Hajar, the floor is yours. And you're on mute.
Thank you so much for inviting me this afternoon to your meeting, and I guess it's a pleasure to kind of join you all to present about frailty. Thank you, Rosario, to setting the scene to start with, going in depth. So I think, as you mentioned, congenital heart disease is a lifelong condition from fetus to the end of life, and that is where we come as a healthcare professional from a different background to help and support this patient population. So aim of my presentation today is define frailty as not as best as Rosario has done in ACHG and why it matters now, summarize the health and social consequences of this, share some practical and screening interventions, ideas, and highlight severe service implication and research gaps. So frailty is emerging earlier than kind of we taught in ACHD patient population. So why now? The demographic is shifting. We have ACHD patient population surviving rate is increasing. We have rapidly growing older patient population. We are the largest ACHD center in UK and one of the largest in Europe. And we see that on a day-to-day basis, the elderly ACHD patient population. And it's forecasted by 2030, 1 in 9 adults will be over age of 60 years old. So we have a lot of work needs to be done to care for this growing patient population. So aging in ACHD is not typical aging. So it has multi-morbidity, as you know, kind of we have residual lesion, we have prior surgery, upcoming surgery. We have a lot of patients in heart failure. And obviously we have the burden of arrhythmia in this patient population. As Professor Moon and Professor Morelli have shown in their study, a geroscience perspective helps explain how the biology of aging interacts with the lifelong stress of congenital heart disease, creating a framework for understanding frailty, which is important. So what is frailty in ACHD? As Rosario mentioned, is a multidimensional, reduces physical, mental, social reserve in this patient population. So in combination of vulnerabilities that limits the body's ability to handle the stress. That stress could be physical, cognitive, social, or psychological. So adults with congenital heart disease often show sign of frailty earlier than general population, so we need to adapt models of lifelong care. ESC/ACHD guidelines also highlights the importance of routine review for heart failure, pulmonary hypertension, and arrhythmia. So frailty assessment fits naturally within this framework. So frailty is not just about muscle loss. It's about fatigue, about cognition, about mood, and social support that all matter, which kind of you mentioned integrative care, which is very important in this patient population. So frailty and cognition is the emerging link. So in the middle age, older ACHD patient population, frailty correlates with cognitive deficit and higher healthcare use. Clinical implication is screening cognition with frailty is present and should be done regularly. And cognitive screening should be executed and can be brief and actionable when patient come to for inpatient or outpatient. So what is the health consequences of this? I'm very interested in health-related quality of life, as Philip knows that I'm studying kind of this in more in depth, especially in ACHD patient with heart failure. So frailty is associated with reduced functional capacity, increased hospitalization, and higher mortality in cardiovascular kind of aspect of it. Emerging data in ACHD shows similar pattern with multi-dimensional frailty is linked to poorer health-related quality of life. Psychological burdens such as anxiety and depression, and limited social participation are major determinant of quality of life in this patient population, often outweighing the clinical severity. We are in clinic, we are stressing a lot from clinical aspect, we sometimes forget the other aspect. Integrated care is essential, including physical, psychosocial, and social vulnerabilities are interdependent and together can shape the outcome of the service use. So I have done, so from biological aging to lived experience ACHT patient, I did some focus group recently. And then this is the direct patient quote that's given me from physical and functional impact. They said it's not just breathlessness, it's the constant worry of when my heart will let me down. You start living cautiously even when you look fine on paper, which is very strong quote. From social independence laws, they said, I used to be one helping everyone else. Now I cannot even walk to the shops without planning it, like a mission. Is just tiring and is isolating. And from future uncertain psychological point of view, your life, you live your life in a short burst between appointment, test result, and the next hospital letter. It's hard to plan a future when your body decides that's going to work in pace. So that shows the burden of frailty in this patient population. I didn't put the age, I'm sorry, but this is younger group of patient that you would assume from general cardiovascular patient population who are in frailty. So what we should do is a multi-component. Obviously, exercise and cardiac rehabilitation improves function and quality of life in heart failure and cardiovascular disease. Such a program should be adapted for ACHT physiology as well. Nutrition and protein optimization, counter sarcopenia, so involve dietitian as early as possible. Obviously, vaccination and infection prevention, including dental care in the carditis risk, reducing inflammatory trigger and decompensation. Psychological support and peer network improve health-related quality of life and self-efficacy. And integrated bundle approach, which is exercise, nutrition, psychosocial, vaccination, and multi-dimensional input from every healthcare professional can help and support this patient population. The service model evaluation from individual care to system resilient, so integrated ACHT geriatric rehab approach, which includes CNS-led education, care passport, multidisciplinary case review, and also liaising with our local emergency department or local services that's helpful. Advanced care planning recommended in international ACHT position paper. We should start as early as possible and embed in our standard and our follow-up. A standard emergency contact pathway for providing written escalation plan, unfit plans, and unified out-of-hours contact routing for hospital that were unfamiliar with ACHT care. And obviously, that is close to my heart, using health-related quality of life to assess them as early as possible and intervening. And kind of building resilient pathway is just designing system that doesn't work for 9 to 5 in general hospital, but it works in local hospital and A&Es in the middle of night. So they know what to do and how to approach services and care. So my take-home message today is embed frailty and cognition screening at annual ACHT review, if that is your patient population needing annually or as often as possible. Deliver multi-component program, exercise, nutrition, psychosocial, etc., adapted for the ACHT physiology. Implement written follow-up at kind of local level. And research and priorities, I would kind of emphasize developing and validated kind of ACHT-specific frailty or health-related component aspect that can help. Evaluating rehabilitation and nutrition bundle tailored to ACHT pathophysiology. And also kind of, as I said, you know, it needs to be important measure that what matters to that individual patient. These are my references. I'm happy for any question at the end. Thank you very much.
Thank you very much, Hasha. So we maybe can move now to the third speaker, Christina Silman. Christina Are you here? Yes, I think yes. Christina is running the outpatient art specialty service in the Sutter Medical Center in Sacramento. And Christina, please, the floor is yours.
Thank you. Can you all hear me okay?
Yeah.
Okay, great. I'm going to try to share. I'm on two different screens because I had some technical difficulties, so I apologize. I'm going to go ahead and share. Can you guys see my screen? Is that available to everyone? Okay, great. Thank you so much for the opportunity to speak with you all. Hajar and I switched, so we're kind of going backwards to the pediatric frailty. I've spent the last 15 years in adult congenital heart disease, but prior to that worked in pediatric cardiology. So I have some experience working in family-centered approaches. And so as we talked about, frailty is this multidimensional concept. Traditionally, back in the 50s, it really focused on the geriatric population. And it was this medical definition that the body, had this capability to handle more strain from further illness or injury. So this could be also considered, vulnerability. But in pediatric populations, this really extends beyond the physical capabilities and really does encompass not only the social and psychological, but also the developmental milestones that children are reaching. So I like to think of, pediatric frailty starting with the individual, the child themselves. And again, we think about the sort of physical manifestations of frailty. Layered on top of that is the psychological, social, how's their neurocognitive functioning? Are they meeting their developmental milestones? And how is their academic performance shaping up as well? When we think about family systems, this child is living inside a family. And on top of that, we're going to have family frailty. So this is an added layer on top of the individual frailty. So this includes things like parental stress, economic constraints, limited social support networks, language and cultural barriers, health literacy of the family, their ability to understand the information. And so let me go back to this. All of these components, one of the things I didn't include also is sibling dynamics as well. If there's another child with some other form of frailty, be it a physical constraint or even something like a learning disability, that adds another layer of complexity and frailty on the family and the parental stress of dealing with multiple children with complex needs. So when we think about transitional care, when the child is going from, childhood to adolescence to young adulthood, that transitional time period is really characterized by this individual separating from the family and moving towards a more autonomous adulthood. Everyone goes through this. This is a challenging concept in the sense that frailty can be described as like dependence on others, and children are inherently dependent upon their parents. And as they're moving towards adulthood, they're moving away from dependence towards independence, and the parents are moving from dependency towards letting go of that dependency. And so there's a lot of different family dynamics that are coming into play here. So we have the parents who can, have challenges of letting go, as this mother is holding onto her daughter, moving into her dorm room demonstrates. And so when you're thinking of family frailty, this individual and family dynamics, you really have to tailor the transitional interventions around both the patient and the family in this integrated manner, so that you avoid stigma, you're optimizing that patient autonomy and validating the parental support, and because that will likely continue despite the individual's autonomy. And really the goal is to avoid lapses in care that lead to poor outcomes. This is a very tenuous and vulnerable time for congenital heart patients because they are at a higher risk of having these lapses to care because of that dichotomy between dependence and independence, and the parents letting go and keeping also a supportive role in the child's life. So future needs, we definitely need to have more clearly defined frailty screening tools for both the pediatric patient and the family unit to utilize within the clinical setting. And we need to have meaningful interventions that improve outcomes. So, minimize those lapses in care, heighten the patient autonomy and meeting them where they're at. We have a lot of patients that are intellectually disabled, and so there may be a cap to the degree of autonomy that they're able to achieve. And so helping that patient meet their heightened or optimal level of autonomy while also supporting the parent and the family caregiving center. So having this targeted care planning approach with a family-centered mindset of not only assessing the patient, but also their parents and the family around them. Okay, that was quick. Thank you so much.
Thank you so much, Christy. Short and sweet, that is what is often important. Thank you so much. And without further ado, let us go to the last presenter of this webinar, Dr. Ariana Magon. So we started in Milano and we go back to Milano. And Ariana will guide us through some thoughts for future innovations and emerging models. The floor is yours, Ariana.
Thank you. Thank you for the introduction. So give me a few seconds to share my presentation. Do you see my presentation?
Not yet. Yes.
Do you
This
hear
year
me?
now. Yes.
Okay. And do you... Okay. So good afternoon, dear colleagues. It's a pleasure for me to conclude this wonderful webinar. I would like to start with a few questions that summarize the main topics discussed and highlight some aspects that my colleagues in their previous presentation have already addressed. And the first question is what frailty being and how it can be defined? No, the answer is yes. We know that frailty is a multidimensional and complex condition, and its conceptualization go behind age alone. Frailty can also be observed in young adults who may be pre-frail or are really frail. In Europe, more than 50% of adults aged over 50 years are considered pre-frail or frail. And more specifically, is the prevalence of frailty known in pediatric and adult individuals with congenital heart disease? Yes, we have an initial body of evidence describing frailty in both pediatric and adult individuals with CHD, and given the increasing number of individuals with CHD reaching adulthood, greater attention in recent years has been devoted to better conceptualizing and measuring frailty phenotypes in this population. Current evidence indicates that approximately 40% of adults with CHD aged over 15 years are pre-frail. And as you can see, the mean age of adults with CHD identified as frail is slightly lower than the mean age of frailty observed in the general population, which typically occurs at around 50 years. And this condition is particularly true considering that adolescents and young adults with congenital heart disease may also experience neurodevelopment disorders or present social, physical, mental issues, which together contribute to a condition of frailty even at young age. And the last question is, do we have interventions in preventing or managing frailty in individuals with CHD, and how to implement this intervention within models of care? The answer is no. because evidence on effective intervention strategies and their integration into care models remain limited, particularly in the CHD population. So this is one of the key areas needed to better explore and improve. And we also know that higher population frailty consequently leads to a greater healthcare system burden due to the inappropriate use of emergency services, frequent hospital readmission, increased long-term care utilization, and substantial waste of financial resources. And so managing frailty as a public health priority across healthcare system and a global health challenge. And I'm wondering what are the components of an integrated model of care and how it works. So to explore this, I've tried to develop a framework for managing and preventing frailty that we can review together. The first component of the framework that I have proposed is the appropriate selection of interventions. By definition, an intervention is a single method or technique designed to facilitate change based on the adoption of best practice recommendation or evidence. And as you can see in this slide, I have a report the list of common interventions using for preventing or managing frailty in general chronic conditions, such as case management, preventive education, and home-based support strategies, intermediate care services, comprehensive geriatric assessment, social support, and technology innovations. And this is a not exhaustive list, but report the main interventions cited in the literature. And the selection of one intervention or a combination of them depends on which dimension of frailty is affected. For example, if we have a patient with a social frailty, I will select a social support intervention. Otherwise, if we have a patient with a social and physical frailty profile, I will probably select a combination of these interventions. And these interventions are sometimes adopted from a system-wide perspective, and the literature show a moderate effectiveness overall. So in this scenario, we still lack sufficient evidence to determine which interventions are most effective in preventing and managing the frailty phenotypes in the CHD population. The next component of the framework is a model of care. A model of care outlines how health services or interventions are designed and delivered to an individual or population group for a specific condition or need. So, in other words, we can consider a model of care as an integration of interventions in which role, activities, and resources are clearly defined and function together. The model can be oriented toward different levels, system level model of care, community level, or individual level. And in this slide, I have reported the name of several model of care used in the general population with a chronic condition adopted in several countries. And what are the proxy outcomes? Are indicators that refers to the performance of an integrated model of care, mainly related to the sustainability, feasibility, applicability, and cost effectiveness. So how do we integrate the model of cares in real world practice? And we know that even when a framework exists, a local adaptation remains essential. And in this slide, I have reported the main principle turns around the integrated model of care for frailty management. And this principle referring to screening, comprehensive geriatric assessment, individualized care planning, multidisciplinary teamwork, and the involvement of patients and informal caregivers. So these evidence are true and apply to chronic condition, but the answer is how can we adapt this principle to prevent and manage frailty in CHD population? And currently we have not specific guideline or evidence recommendation on how to manage frailty in individuals with CHD. And implementing a model of care is not easy, and I would like to share with you some of the main barriers that could undermine the implementation of an integrated model of care for frailty management. And these barriers can be classified into 3 levels: macro, meso, and micro level. As per macro level, we refer to system fragmentation, financial limitation, or regulatory constraints, and meso level referring to operational and procedural challenges, for example, poor communication or low interprofessional collaboration. And micro level mainly refer with a lack of competence, for example, among healthcare professionals and factors related to patients or communities. And the last component of the model regards the distal outcomes that are the long-term consequences of an intervention process or condition, mainly related to health status or economic benefits that we also see in the previous presentation. And distal outcomes in a model of care for frailty mainly regards quality of life, such as support, patients or caregiver satisfaction, psychological status like depression or anxiety, burden of caregiver, but also cost of services and the rate of institutionalization or mortality. And so, in conclusion, these are my take-home messages. We need to strengthen the primary evidence on the efficacy and effectiveness of discrete or combined intervention for preventing and managing frailty in the CHD population. We also need to develop a comprehensive understanding of the determinants that may undermine the implementation of the integrated care models and to identify potential strategies to address them. And specifically for CHD population, the actually care models and to identify potential the actually integrated and complex model of care is the transition program. However, this model is primarily conceptualized for adolescents with congenital heart disease to support and ensure a successful transfer to adult care services. And 2 main questions arises, in my opinion. The first is, how can a transition program serve as an effective model of care to mitigate or prevent frailty in the adulthood? And which components of the transition program are most effective in managing early stage of pre-frailty in adolescents or young adults? So we need to further develop and co-design integrated model of care that promote healthy aging and lifelong health management for individuals with congenital heart disease. And these models should encompass all stages of life and become a programmatic goal shared by scientific society, health authorities, and regulatory bodies to define what is still mainly missing: a comprehensive health service policy framework for managing frailty in CHD population. So I'm finished and thank you.
Thank you very much, Arianna. Thank you to all the speakers. As a physician, I'm very happy to be part of this webinar because I'm learning so many things. Maybe we may, what do you think, Philip? We may ask participants if they have any questions for our speakers.
Correct. And there are two ways to raise your questions. Either you can raise your hand and then we can give you the word. Open your microphone and you can ask the question. Or if you prefer to put your questions in the chat, that is also possible. Both Professor Gessa and myself, we have access to the chat, so we can see who is asking the questions. While we are waiting for questions from the audience, I have a question to all the speakers, and these are things that you have raised in all your presentations, but I would like to really bring it to the surface and put a focus on this. The question is, in your opinion, what are the key interventions that should be done? And again, in the 4 presentations, this was addressed, but I would like to go over all the speakers again to highlight this. Rosario, what is, in your opinion, what are the key interventions?
I think the key intervention is design a stratification of the population. So looking at what we have in terms of characteristics in our services and respond to each category of patients that we have. So basically, we have to understand the proportion of pre-frail or frail patients that we have and which aspects are compromised, because we have to start considering our patients flows. So patients that we can have in some services here in Milan can vary a lot from patients that we can find in Sweden or Finland in other centers, because the umbrella term congenital disease, of course, involves different clinical conditions, but also social conditions. So I would like to say we should start from what we have to design our intervention and design intervention based on what we have.
Okay, thank you. Hajar, what is your take on this?
I think it is important for us to use at this stage, because there isn't such a thing as a tool to assess this patient population. I think it would be good to start to use generic assessment tool to assess the frailty in ACHD patient population. And then from that, we can have a rich data to see what is the key themes comes out. And therefore, in the future, to use that as a research tool to find out what is the specific for this patient population, and we can condense it to make it a shorter tool to assess this patient population. I think that is the key and important aspect. And as we all of us discuss, all of them are multidimensional, from physical, social, psychological aspect of it, which comes together affecting quality of life. But we need to start from somewhere using generic frailty tools to see what is the key themes comes from that, to narrow it down to ACHD patient population.
Thank you. Christy?
I'm going to piggyback off of what Hajar said, but I think we have to look at it in a lifespan approach. So whatever tools we develop have to be adaptable for each stage and phase of life. So something that assesses the young child into the school-age child, into the teenager moving towards that transitional period of young adulthood, into starting a career and starting a family. And now the family of origin dynamics might change as they get into middle adulthood and have children of their own. They are becoming caregivers. That's a level of frailty that wasn't really seen before. Now, if they have a child with complex needs, or even just the act of caregiving could make them more vulnerable. And then as they move towards older adulthood and geriatric age, additional comorbidities, all of those things. So again, I think whatever we develop has to be adaptable for each phase and stage of life. So it's going to be difficult to find a one-size-fits-all screening and interventions, and it really may come down to more qualitative interviewing processes that encompass all of the different domains and is adaptable. So it's sort of like almost like an algorithm of, if they're at this in this domain, if there's these challenges, then you go this direction, and sort of this adaptable algorithm that changes throughout the lifespan as well. So the complexities, I think, are abound. And intervention wise, I personally believe that the strongest one is to avoid the lapses in care. So my personal approach clinically is to always start with assessing any barriers to continued care. So whether that be economic, psychological, transportation, any of these things that would prevent ongoing medical care is the priority number one for me in my clinical practice. And I believe that that's the crux of continued frailty. If they cannot even get to care, then we're not even going to be able to help at all. So that's my thoughts.
Okay, thank you. And then finally, again, the question, what are key interventions? Ariana, what is your take?
I agree with the colleagues that choose an adequate intervention is not easy matter to do, because we consider local barriers, a local adaptation that is could be not the same across the country, and another aspect is the personalization of intervention, and sometimes one intervention is not sufficient to answer to the need of patients, but we consider an integrated a bundle of interventions to better answer to the possible frailty phenotype in our patients. And also agree that we adopt a lifespan perspective when we speak about frailty. And so this is my opinion.
Thank you so much. I'm having a look at the participants and the chat. So far, no questions.
Maybe I have a question. As you said, short and sweet. Okay. But as a physician, I was thinking about the influence of frailty for risk of hospitalization and also risk of mortality among our patients. What do you think about that? It's a question for everybody. It's just like a brainstorming.
Thank you. I can start saying that this is why we have to speak about frailty, because we have to embrace the complexity. And I understand that from a clinical and specifically the, let's say, physician standpoint, it's not so easy to embrace the complexity around around speaking about frailty. But you're right, because if we start from assessing what can define this phenotype, we can avoid hospitalization, mortality, clinical deterioration, simply because frailty allows us to work in a proactive way. Massimo, you know, as a physician, that sometimes you have to intervene in condition of stability to avoid deterioration of the situations, and sometimes you do in the real world life this work of embracing and practice frailty, because a lot of time for managing these specific clinical cases you have to work proactively to do something to avoid the clinical deteriorations that we can anticipate. So this is in practice embracing frailty as a paradigm of work. Of course, from a research standpoint, we have to clarify and inform the practice about what can work better than other interventions. And as I said before, and everybody, I think, agree that the point is that frailty is an umbrella term with different aspects. So it's also a matter to simplify the different inputs that we have from the different source of data into actionable interventions. As Arianna said, the bundles can work. As Christina emphasized, the lifespan perspective is absolutely relevant, because what we do when we design intervention from pediatric population probably is different from what is needed to the geriatric, or let's say adult congenital heart disease population. So from my standpoint, it's a matter to trigger the need to embrace complexity. My last message is that we need to find a trade-off between standardization and personalization. And this is what research can do. Help clinicians to find this trade-off. Because in the real life, sometimes we perceive the algorithms, the protocols, as something too much strict, rigid. And it's not, because very well-designed protocols can give us the freedom to personalize the care for our patients. And I have, let's say, in mind the experience of your transition outpatient service. And this is an example of embracing the complexity of frailty when transition care programs are designed not in the research, let's say, arena, but in the real life standpoint in managing patients.
Shall
Thank you,
I?
Rosario. Yeah, of course.
I think from clinical perspective on the floor, it's important to educate the patient, because that's important for patient to know the sign and symptom of deterioration, as frailty is multidimensional, and to take action, because I see a lot of patients on the floor with heart failure because they're accepting that is me, they're resilient, they don't want to seek help, and they seek help when it's too late. Then they have to be on level 1 on a specialist center, on tertiary center for a specialist input and support and treatment. So I think if we educate and empower patient with the knowledge that when and how to seek help, I think we can prevent a lot of unnecessary, unplanned hospitalization, which we see on the floor day in, day out. So I think that's the key thing. And obviously, on top of that, kind of assessing each time patient come to outpatient as a trigger for them to think what is the sign and symptom and seek timely help before reaching the deterioration stage that would be kind of too late, unfortunately, for some of them. So all of them comes for us working together with the patient, as Rosario said, individualizing them, the care to them, so they can have better care and understanding of their own individualized need.
Okay, and lastly, I'll add, I think Hajar hit the nail on the head that this is frailty care is preventative care. And you have to think about what is the goal of congenital heart care. The goal is that we help our patients live their best life for as long as possible, and they die of something unrelated to their congenital heart disease. That is our 30,000-foot view goal. And if we are able to help them through that lifelong process by minimizing the impact of their congenital heart disease on their quality of life, on their functioning, on their social life, on their psychology, so that they're able to optimize their life within the context of being born with a serious heart condition and live an optimized life for as long as possible, and ideally die from something unrelated to CHD at a very old age, then we've done our job. So I think frailty is the crux of preventative care for a disease that they are born with, and we're preventing that deterioration and highlighting optimization of their care. That's how I would summarize it.
Thank you.
Yes. Okay. Yes, I agree that education, prevention are a key strategy, and maybe another point of view to consider is that sometimes this intervention could done in a hospital setting, but it's also important in integrated care models to strengthen the relationship between hospital setting and primary healthcare context where patients live, and are the ideal context to identify the symptoms of the condition of frailty that sometimes in hospital context is not able or difficult to identify and monitoring. So expanding these strategies and intervention not only in the hospital context or in an acute setting, but also in primary healthcare setting is maybe the best solution of an integrated model of care, also to prevent some distal outcomes that may be mortality or hospitalization.
Okay, thank you. Philip.
Yeah. A question to the two clinicians in this group, Christy and Ajar. Christy, can I start with you? You presented this concept of familial frailty, and I think that is a fascinating thing. We typically look at frailty as an individual aspect. You rather bring it to the system around the patient as well. Based on your experience, clinical experience, both in pediatrics and in adult care, do you see this aspect of familial frailty? And how do you see it? How do you notice this as a clinician? And what did you do about, or what do your peer care providers do with this?
Yeah, that's the crux of a lot of what I do clinically, especially with my transitional care. So it is a familial assessment. So what are the dynamics of the family? It's that qualitative interviewing, getting to know the family, building trust, identifying who the primary caregivers of the patient are. So it's not always necessarily a mother or a father. It can often be a grandparent or an aunt or an uncle. When patients come to my clinic through transition, especially if the patient is intellectually disabled and unable to make decisions for themselves, or especially if they're nonverbal, identifying the support in place for the parent or the primary caregiver. So that's one of the first things I assess. Who cares for this patient day in and day out? And if they only list one person, that is a concern for me. And so then it's involving my social workers to find out what community resources do we have for caregiver support, for respite care, and then what is the long-term plan? Because the goal is for the child to outlive the parent. So what happens when the parent, who's the primary caregiver of this patient, becomes elderly and frail, and their ability to care for this patient is no longer there, or unfortunately they pass away? What is the plan for this patient? And so I have that very real conversation with the family about what is the long-term goal for their care past your lifespan, and who are the resources in your life, be it siblings, aunts, uncles, grandparents. Well, grandparents don't really count because they'd probably passed on as well. And then if there is none, then really pulling in the social support of our social workers to say, okay, what institutions or facilities do we have to plug these patients into, and to continually assess when it's time to move them out of the home of origin because the primary caregiver has become too frail to provide caregiving. So I think these are really important assessments that start very, very young and should continue all the way through. I also think it's interesting to think about even not our, our intellectually disabled patients, but even our, complex congenital heart patients who have elderly or frailing patients. I always tell this story. I had a 50-year-old patient. She worked a job full time, very, competent, came in with her mother. And I said, what medications? Her mother was 90 years old. I said to the patient, what medications are you on? And she turned to her mother and said, Mom, what meds am I taking? And I said, oh no, like we have to switch that. But that codependency or that relationship of caregiving had not been formally handed from the 90-year-old mother to her 50-year-old daughter, who was fully capable of taking on her own care. And so that is what I am trying to avoid in my clinical practice. I want the patient to be as autonomous and optimized as possible. And if they cannot do that completely autonomously, what is the plan to caregive them for the rest of their life, keeping in mind that they will likely outlive their parents of origin or their caregivers of origin?
Thank you. Ajar? Ajar, what
Yes.
are your thoughts? Yeah.
On the question you asked Christy, I think Christy touched on a key aspect of it. No matter at what age the interdependency is there. So the family support, we tried in transition to engage family as much as possible, because there's a lot of visible and invisible learning disabilities out there for patient population. Some of them is not documented or tested, or is not available from genetic testing. So we try to involve the parents, carers, etc., as much as possible. But we try at a young age to make sure as much as possible that young adults understand their care and can navigate the adult service as much as possible. And I think if we are not doing it, we are failing during the transition. I'm not saying we are perfect, but that is the aim. We have to provide as much information to that young adult to look at them, to target them as much as possible. But we have to be mindful that there is a lot of learning need. There is that the individual cannot look after themselves independently, and that we need to bring the wider social care into it. I have the similar experience of Christy and people coming in their 40s, and the mom and dad in their 60s is still coming, and they bring the mom and dad rather than a partner or a husband to help them and support them to answer some of the questions. That shows we failed. We are not doing our job as best as we could, and we have to reverse back and start from somewhere. But that's a reality on the floor day in, day out, that we cannot address every individual care need, because they have to engage at some extent as well. So it is a challenge, because some disabilities invisible, and we are learning more about ADHDs and other kind of learning need these days, within the Europe at least. So there is a lot of need still that needs to be assessed, but the codependency is still there, and I agree with that, Christy, that's still present.
Great, thank you. Massimo, do you have further questions?
No, I think we are right in time. Maybe you can wrap up.
Yeah.
The conclude, Philip.
Indeed. I think it's clear that frailty is something that should be more on top of our mind than it has been so far. It is a topic that is emerging, that is present, and the attention for this is growing. But clearly, there is a lot we can do based on what we learned from the experts today. Screening, multi-component program with different aspects, being aware about the problem and looking upon it from a system point of view, not only looking at the individual patient, but also the surroundings. Want to thank the speakers of today. I want to thank the ERN for organizing this webinar, and I want to thank Massimo for co-chairing this this session. Thank you so much. Have a great evening for the people in Europe, and have a great remaining of the day for the people in North America. See you. Bye.
Bye.
Thank you very much.
Bye.
Thank you.
Thank you.
Bye. Thank you. Bye bye.